We welcome this evening. My name's Willie Rennie. I'm the member of the Scottish Parliament for North East Fife. This is the debate, as it says on the screen, about assisted dying. And I'm really pleased that so many people have come this evening. It's looking like it's going to be an interesting debate, which I hope that we'll all benefit from, including ourselves. You have recordings here, so there's a video going to be taken, a recording of the event, which will be put online afterwards. So if you don't want your face shown, don't turn round. There is no plan for a fire alarm, so if there is one, if it goes off, it's real, and head straight back out that door again, turn left and straight out. Just follow the signs, and you'll all be fine. So we've got some of the key players, I think, in the whole debate in Scotland about assisted dying with us this evening. Of course, you'll know Wendy Chamberlain, the Member of Parliament for North East Fife, my colleague. But we also have Liam McArthur, who's my colleague in the Scottish Parliament, who is proposing the bill and has been working on this for what feels like years now, Liam. So he's giving evidence, I think, to the committee next week, so you've got him on top form just now. And then we have Dr. Sarah Mills, and Sarah is a general practitioner, a GP in Cooper, but she's also a member of the academic staff here. She's a lecturer in academic general practice, and she's given evidence to the Scottish Parliament on this very subject. So on our own doorstep, we've got one of the experts. We are planning to, the running order is roughly, once I've sat down, we're going to allow Liam to speak for 10 minutes, and he'll just introduce the bill, and you've been given a note, hopefully, which you'll all have, which sets out some of the details, so you don't have to take any notes. So he'll do 10 minutes at the beginning, and then we'll have Sarah, who will give her viewpoint, and then Wendy will explain the Westminster bill, because you'll know there's a bill going through Westminster, which is obviously different from the one in the Scottish Parliament. And she'll explain some of the differences. And then we're going to open it up to questions and contributions. And we'll have some roving mics that will go around the room. So start thinking of your questions now. We prefer succinct and sharp questions if you possibly can. We'll take 3 at a time. If you don't have a question and you just have a point of view, that's fine as well. But if you can try and hone it to as short as you possibly can, so that we can get as many people in to speak as possible. As I said, I'm hoping to be informed. I'm sure Wendy is herself as well. But I hope you benefit all from this as well, because I think it's an incredibly important issue that I think we all need to embrace and understand fully. I haven't made up my mind what I'm voting. We're not expecting it until later on this year, so there's still time to contemplate all the issues. But I'm hoping that you're going to educate me as well this evening. I know all the arguments. I've heard, I think, all the arguments, but I've not heard how you say them and the emphasis that you put on them, and I've not heard about all your personal experiences. And that's what I want to hear this evening. I want to know what emphasis you put on different arguments. It's an incredibly important issue. I have grappled with it for a long time now, and I'm hoping this evening will help inform me and make my decision. And I'm sure Wendy will be in the same position as well. She'll set out her own views later on. So again, thank you very much for coming. I'm really grateful for Liam and Sarah in particular for giving up their time this evening and being able to help us with this discussion. And without further ado, I'll hand over to Liam McArthur.
Make sure I'm connected up. Everybody hear me okay? Excellent. Look, can I add my welcome and thanks to that offered by Willie. I've done a few of these events. As Willie says, it may feel like years. It has actually been years. For me, I think I first indicated my intention to bring forward a bill to allow terminally ill adults with mental capacity access, should they so wish, to the option of an assisted death. Shortly after the last election, which was May 2021, I launched the proposals out for consultation in the September of that year, and that consultation concluded in December. It is and remains, it was and remains the the consultation for a Members' Bill. That has attracted the most responses ever for a Members' Bill since the Parliament was re-established in 1999, just over 14,000. And I think reflecting the interest there is in this issue. And it's not just the issue of assisted dying. What's been clear from the outset is this opened up and has opened up a much wider debate about how we die, about the choices we have at the end of life. It's opened up a debate, I think, long overdue, around issues to do with palliative care, a part of, I think, medicine that very often struggles to get the attention because of the focus on other elements of the health service. And all of that, I think, is very valuable. It is an emotive, it's a sensitive issue. People have very strong views for or against. But I've found from doing a lot of these events and from the conversations I have that very many people just have questions. They may be broadly in favour of a change in the law. They may broadly have kind of apprehension and think that on balance it's maybe not a course they want to go down. But almost without exception, they have questions. They have questions about how it may work in practice. And sometimes it's difficult to answer precisely what that will look like in a Scottish context. We've got assisted dying laws now in many states and countries around the world. Around 300 million or so citizens around the world live in jurisdictions where there's assisted dying. But there are no two pieces of legislation, no two assisted dying laws that are exactly the same. I would say that there are two broad models. There's a fairly expansive model that's been in place in the Benelux countries, in Netherlands and Belgium, and more recently in Canada for a number of years. And then what I would call a terminal illness mental capacity model that was first introduced in the US state of Oregon back in the late 1990s, 96, 97, and has since been replicated pretty much sort of word for word, or in terms of the safeguard, broadly the same across a dozen states in the US, and more recently in all of the states in Australia and New Zealand. And the model I'm looking to introduce, the bill that I introduced formally to Parliament in March last year, follows that same model and has many of the same safeguards. It draws on the experience. This is the third bill that the Scottish Parliament has dealt with since 1999. The other bills have fallen at the stage that we are coming up to, likely in the middle of May, which is stage one, which is around the general principles, which accepts that there may be changes that are needed to the bill, but that asks MSPs whether or not they believe a change in the law. And the general principles of the bill I've introduced are ones that they support. So we've never got into the detail of, well, if you have concerns around the definition of terminal illness, you have concerns around how capacity might be assessed, you have concerns about how coercion may be assessed, or any of the other components of the bill. The area where those can be teased out and ideally addressed is through stages 2 to stage 3, which are the amending phases, and we've never managed to get to that point to date. So as I say, my bill would allow terminally ill adults with an advanced progressive terminal illness from which they are not expected to recover, with mental capacity and capacity to understand the implications of the decision they're making in terms of an assisted death rather than a broader capacity issue. That would need to be diagnosed by two separate medics, one of whom could not have a prior relationship with the patient. There would be assessments as part of that to determine the rationale for why an individual had made the application, to determine whether or not there had been any undue influence or coercion involved, and to ensure also that the patient is aware of all of the treatment and other options available to them, including palliative care. And I think what we see in many of the jurisdictions, the Health Committee heard this evidence from witnesses involved in the process in Australia, that actually through the introduction of assisted dying laws there, what they've seen is an improved engagement with palliative care. They've also seen increased investment in palliative care in many of the states as well, recognising that the debate that we are having here, which is very similar to the one that they had in each of those states in Australia and previously in the US, has given rise to questions about how are we delivering these other health and care services, and where I felt appropriate additional investment and changes are made. So I've never seen this as an either or. We need good and we need better, probably access as much as the quality of the palliative care itself. But we also need to provide the choice of an assisted death for those who very often have reached the end of palliative care. We see in most of those jurisdictions, all those jurisdictions where assisted dying laws are in place, that the vast majority of those accessing it have been in receipt or remain in receipt of palliative care at the point that they access it. We also see around a third of those who make an application not then going ahead with it. And there could be a variety of reasons for that. Possibly they change their mind, but more often than not, it's just that they find that the other care that they are receiving is sufficient to meet their needs. In the sense, this has been an insurance policy that if things get too much, that option of an assisted death is available, having a palliative effect, I think, or a palliative benefit as well. So we'll get into the detail of this, I'm sure, in terms of discussion. Sarah and I were comparing notes beforehand. As Willie says, I'm before the committee in Parliament, the Health Committee, next Tuesday. Sarah's already had that joy. And I think the Health Committee has done an excellent job in eliciting both written evidence from the widest possible range of stakeholders. The response to the call for written evidence it issued, again, reflected the kind of response that I got to my consultation back in 2021. And the oral evidence sessions have been extensive and offered a range of witnesses an opportunity to articulate either the concerns they have or the questions that they have about the bill. So that process, I think, has worked very well. The committee will be expected, after I've given evidence, to come up with a stage 1 report. I wouldn't expect them to take a view either for or against the general principles. This is a vote that will be left to the individual conscience of individual MSPs. It won't be whipped as such, and therefore I think it's unlikely that the committee will take a view. What they'll probably do is air the evidence that they've received. They may, where they all agree on something, suggest that if this is to go forward, we would wish to see changes in this area or that area. But it will be left to MSPs, all 128 of us, to debate it and vote on those general principles, probably second half of May this year. So it's been a long process, but I think for an issue like that, like this, that's entirely right and proper. And as I say, I think what it has is exposed a whole range of different issues that we should be grappling with. We should be trying to find answers to, probably rather more than we have. I often remark that in Parliament we spend an awful lot of time debating how we improve the quality of life of people, but precious little time talking about how we improve the quality of death. And it is a subject that many people find uncomfortable and difficult. But I think this debate around this bill and the bill that Wendy will talk about in Westminster has allowed that debate to happen. And I think, if nothing else, that is a very positive thing. So I look forward to hopefully engaging with the questions that you have, listening to the comments that you have. I mean, unlike Willie, I've kind of made my mind up on this. It's a bit late to perform a spectacular U-turn at this stage. I'm sure Sarah may try to convince me otherwise, but I am genuinely interested, even at this late stage, to hear the comments and questions that you have. Because I think if we get through stage 1 into the amending phase, there will be an opportunity to try and get the detail right. Because as much as I believe there is now ample evidence from around the world about how these laws work in practice, can be worked safely in practice, we need to make sure the detail of whatever we introduce here in Scotland is tailored to the circumstances and the needs here in Scotland. So thank you once again for being here. Thank you, Willie, for inviting me, and I look forward to hearing what Sarah has to say and what you have to say. So thank you very much.
Okay, grand. Good evening. So I'm Dr. Sarah Mills. I'm a lecturer in academic general practice at the university here, and it's a huge privilege to be asked to speak here, and thank you for all organising that. As Willie said, I presented evidence to the Scottish Parliament on my research and the research of others. My research focus is unscheduled care use predominantly in the last year of life, and it was in my capacity in that respect that I was asked to go and speak in Parliament. For context, here at the University of St Andrews, we're doing a lot of research on care towards the end of life, and particularly how we can improve that for people, how we can improve identifying people who have palliative and end-of-life care needs, how we can identify the equity of access to palliative and end-of-life care, and how we can improve the patient journey towards the end of life. And we've been hugely privileged to have that funded through the Chief Scientist's Office, through Marie Curie, and a number of other sources. So that's the work that we're doing, and certainly I'm very happy to speak to any of that at any point. The evidence that was presented to Parliament was very broad. It was from a number of different perspectives, and it was from individuals and academics as well as organisations that represent doctors and researchers in this area. And I've been asked to set out briefly the evidence that was put forward by myself and others to the committee. So I'll start by acknowledging that this is a hugely emotive issue. Most people here tonight, most people in Scotland aren't academically interested in this, aren't sort of interested in it from a research perspective. They're interested in it from an emotive and personal position. And certainly, I think it's important to acknowledge that. It's also important to acknowledge that the majority of people who are putting forward this legislation are doing so from a place of compassion, are doing so from a place of wanting to provide care for people who are potentially facing difficult situations up to and including the point of death. And that has to be acknowledged. It is very true that the majority of people who are interested in pursuing assisted dying are doing so from a place of autonomy and from wanting a sense of control. Certainly that can be provided in the majority, but certainly not in all cases, by high quality palliative care and by improving access to palliative care, and that's very much the perspective that I'm bringing in that respect. I would also say that tonight is very much about the bill as opposed to the moral, ethical, philosophical, metaphysical concept of assisted dying, and that very much, while we may find such a debate engaging and entertaining, and certainly it wouldn't be the first time that I've entered into a moral or philosophical debate, particularly in my student days here at St Andrews, we did this fairly enthusiastically and regularly. But tonight it's very much not about the broader philosophical concept, but about a piece of legislation that is very real and that has the potential to affect all of us and how we approach end of life as a society. And it's very much in that respect that I'll be putting forward evidence. I would also say it's perfectly plausible for somebody to support the concept of assisted dying, but to find very real issues with the legislation as it stands, either in this country or in Westminster. So in that spirit, I'll start with summarising some of the research that was put forward. We heard that very much in Scotland, 1% of the population is in their last year of life at any one time, that those people account for 10% of all hospital admissions, but 25% of all hospital bed days, because admissions for people in the last year of life tend to be longer. That cumulatively, people in their last year of life account for 35% of the NHS and health and social care budget that is spent. So it's an enormous issue that affects all of us. And we know from my work and the work of others that 95% of people in their last year of life will use unscheduled care services, so emergency department, GP out of hours, Scottish Ambulance Service in their last year of life. And that's not because everything's going well, that's not because they're having good care and they're comfortable at home, that's because things have gone wrong and they've sought emergency treatment escalations to deal with pain with palliative care symptoms that are currently being unmet. We heard from Marie Curie that 90% of people in Scotland have the potential to benefit from palliative care, but that 1 in 4 people in Scotland is currently missing out on palliative care that could be expected to give them some degree of benefit and comfort. And that's huge. That's 1 in 4 people who could have benefited from palliative care who don't currently have access to it. Since COVID, there's been a sustained 35% increase in deaths in the community. So we've seen the number of people dying in the community, so outside of hospital, go up by 35%. And that hasn't fallen. That stayed the same ever since COVID, so for the last 5 years. We have not seen an increase in the prescribing of community medications that are associated with end-of-life care, so just-in-case medications. So that stayed static. And that's very much because we were already at our capacity for delivering palliative care in the community before we had this sort of an increase. And actually, there has not been an increase in GPs. We've seen an 8% fall in GPs in this country in the last 10 years. There hasn't been an increase in district nurses. There hasn't been an increase in the amount of time or staff or resources we have in the NHS to meet this. So we're very much seeing a system under pressure, a system not currently coping with the volume of care that's trying to be delivered. We know that only 4 in 10 people who die from cancer have access to just-in-case medications in the community, and that 1/3 of people don't ever get prescribed a strong opioid in spite of being diagnosed with advanced cancer. So there are a number of things that can be done that are basic palliative care things that are still not happening on a wide scale. We heard from the Royal College of General Practitioners and from the Royal College of Physicians that prognosticating about time expectancy for life expectancy is accurate in hours, weeks, and days, but that at what point you try to extrapolate to months, the margin for error can well be years. And we've seen numerous cases where that's been the case, where we just quite simply have gotten it wrong. And we see that the difficulty in identifying people who have palliative care needs. So in parts of the country where they have truly excellent palliative care services, like Yorkshire, where they have the Gold Line service, which is a bespoke palliative care service with a single point of access, where you call one number and the phone is answered by a nurse, as opposed to by a call handler who tells you get a call back in 4 hours that turns into 6 hours. Even then, half of the people who die in those locations don't have access to those resources because they're not identified as having a palliative care need. They're not picked up early. And the majority of people who are told that they're dying are told within weeks of death as opposed to any earlier. So the timescales involved in this are hugely challenging. Coming on to issues with the current legislation, and there are, with apologies, there are a few that I think are worth noting, and that certainly were brought up in Parliament when I was there. In terms of the definition of people who would be expected to be able to access assisted dying under the bill, it's defined as people who have an advanced and progressive condition that could be reasonably expected to cause their premature mortality. There's no agreed definition of those words in medicine. You don't pick it up and say, well, this is advanced and this isn't. Doesn't fit nicely into boxes. It may well be that somebody who has a condition that causes them great suffering does not have a progressive condition. So if you have an enormous stroke and are very, very disabled from it, even to the point of locked-in syndrome, it's not necessarily progressive. It's happened, but it's not progressive. So would that person be covered by the legislation? If you have somebody who has 3 or 4 fairly mild to moderate conditions, but actually they're 97 and they're dying from all of them because you can't match kidney failure and heart failure particularly well without knocking them off with medication, well, that person isn't covered because they don't have an advanced condition. They have multiple run-of-the-mill conditions. However, somebody with poorly controlled diabetes, where it's advanced and progressive, would actually be expected to live a relatively good and happy life and relatively well. They would be eligible for this. So it's very challenging in terms of how do you write a bill that would cover a condition for which you could reasonably expect that somebody would not necessarily want to continue to be alive in that condition. And again, people's responses to different conditions are widely varied. But I think most of us could foresee a condition where we might think, actually, I would not want to live in that state, is not necessarily covered by the legislation as it stands, whereas a number of other conditions are. And it fails to account for multimorbidity particularly, and we know that actually the majority of deaths in Scotland are going to be due to multimorbidity, and that's only going to increase with our aging and multimorbid population. It doesn't address the inadequacies of provision of community palliative care. So at the minute with palliative care, the majority is delivered in the community by general practitioners, district nurses. It's not a hospital specialty delivering its care at the end of life being delivered by unscheduled care and in-hours primary care predominantly. And the workforce crisis in primary care is limiting the capacity we have for absorbing this kind of work. It also doesn't address the amount of GP time or medical practitioner time in the community that would be allocated to the bill. So, for example, provisions that say that you would provide the medication and stay with the patient until they have taken the medication. If I go into someone's home on my way home at 7 o'clock, do I stay there all night if they want to take it in the morning? Or do I pop in at lunchtime and say, well, I've got patients at 2. If you could take it before then, that would be great. It doesn't feel good. It's not workable. It's not compassionate to say to somebody, actually, I have to sit here while you take this. and then just wait. It's a bit tone deaf in terms of providing care at the bedside of someone who is dying, which I've done, which most of my colleagues have done extensively. It also fails to account for the difficulties of actually administering a system where you might have someone who has a conscientious or other objection to providing the care, but they're in a situation in which their patients couldn't reasonably access it through other services. So it's fine if you're in Cooper and Bank Street doesn't want to give it, but Eden Villa does, or even with doctors in the practice. But if you're in Orkney or Shetland, or even if you're in places where actually they have a number of practices that are staffed by locums as opposed to GP partners, you may not be able to access care that's available to somebody else just by virtue of the fact that primary care services are overstretched in those areas. So it doesn't account for a lot of the primary care services within Scotland. It runs the risk of a false choice. So at the minute, we can't say you have a choice between good quality palliative care and assisted dying. We have to say you have a choice between the status quo, which is inadequate palliative care and often completely lacking palliative care, or assisted dying. And it doesn't take into account the failings in health and social care that mean that a number of people would be in a position where the thing that is motivating them to seek assisted dying is often social isolation or pain or addressable symptoms. If I've had one patient where they wanted to die because they didn't have a ramp to get them out the house, so they were completely isolated. Well, the solution is not assisted dying, the solution is building a ramp. There are a number of things that we could and should do better before we put in assisted dying as a provision, and certainly introducing it into an NHS that is still reeling post-COVID and in a health and social care situation with inadequate provision feels like a false choice. In terms of the age limits in the bill, there was a debate with the Scottish bill has 16 as the opt-in clause, so we heard from the children's hospices across Scotland, CHAS, on their experiences of assisted dying, but certainly there didn't seem to be any rationale in terms of research or in terms of in the academic sphere where there was any support whatsoever for having a 16-year-old being able to access assisted dying, particularly in a country where there are a lot of things that are denied to 16-year-olds, like alcohol and cigarettes and things that would reasonably be expected. There was a lack of clarity on the conscientious objection clause. So our understanding from what was said in Parliament was that that would have to be ratified by Westminster and that the bill could pass in Scotland without a clause on conscientious objection, unless legislation was forthcoming from Westminster to allow that to occur. And certainly the thought of having to work in a country where you were required to provide assisted dying irrespective of your personal beliefs, be they religious or otherwise, is concerning to a number of physicians. Certainly the British Medical Association presented their report where the BMA had voted to change from a position against assisted dying to a neutral position in 2020. But the breakdown of that vote was very much that doctors who were in patient-facing roles voted against the change, and medical students and retired doctors voted for the change. And the majority of respondents still said they would not personally provide assisted dying, even if it was legal. So you're in a position where actually the majority of physicians say they would not personally do it, but there may be legislation that requires them to do so unless we're looking to Westminster for the opt-out from that. So that was a concern. And there was concerns in terms of the impact on healthcare professionals and the role between the doctor and the patient, and whether the introduction of the provision of assisted dying would fundamentally change the nature of that relationship, and a concern on the impact that it would have on palliative care, and whether the funding for palliative care would be walked back because of the provision for assisted dying, whether the funding for research in palliative care would be walked back as well. We've certainly seen in a number of countries that has happened. In Canada, certainly the rate of increase for funding for research into palliative and end-of-life care grew at a markedly less steep rate than it was growing prior to the introduction of the bill in 2016. So those were the majority of the concerns that were established. In summary, while it was a response to the very real, the bill itself is a response to the very real desire to alleviate suffering, in its current form it has several significant flaws, particularly the lack of the clear definition and the concerns about how it would be implemented equitably across Scotland, and in a way that takes into account the current pressures onto the NHS. And before moving forward with this bill, there are a number of points that we strongly would urge to have addressed, including the safeguarding for palliative care as it stands. Thank you. They don't do that when I lecture.
Thank you very much for that, Sarah. That was very comprehensive, and to Liam as well for talking through his timescales in relation to the bill. I'm just here very briefly just to talk about, I think there is obviously an assisted dying bill progressing at Westminster as well. That has come into being since Liam's bill, in fact, quite recently. And I just wanted to, I've had a lot of correspondence, obviously, too, in relation to assisted dying. And as Sarah has pointed out, if Liam's bill were to be successful, there would be implications from a reserved perspective in Westminster, not just in relation to what Sarah talked about, but also changes in relation to drugs legislation, because obviously procurement of drugs given for the purpose of assisted dying would have implications too. So I just wanted to give a little bit of a primer in relation to where the bill in England and Wales is. So basically, the bill in England and Wales is progressing through a system called the Private Members Bill legislation. It's very archaic in that literally you write your name beside a number in a big book, and then they pull balls out of a glass bowl, and if you are in the top 20 MPs who come out of that glass bowl, you have the opportunity to bring forward private members' bill legislation on a topic of your choice. And Kim Leadbeater, who was number 1 on that list, so basically guaranteed to have debate time, has chosen to bring forward the Terminally Ill Adults End of Life Bill. Because in Westminster we have both the House of Lords and the House of Commons, legislation can start in either house. And so in this case it has started in the House of Commons. First reading is literally where the title of the bill is read out in the House and the second reading date. And the second reading is the session that you will have seen very well publicised on the media that took place at the end of November, where there is a debate on the general principles of the bill, not the detail of the legislation that Sarah and Liam have touched on. But in terms of the legislation in England and Wales, it's following the same principles as Liam's legislation, in that it's about mental capacity and it's about those who've been diagnosed as terminally ill. Where the bill is now is at what's called committee stage. So unlike the Scottish Parliament, where the Health Committee is considering Liam's bill, there is a bill committee set up specifically for this legislation in the House of Commons. And Kim is responsible for ensuring the MPs who sit on that, and she has deliberately chosen MPs who both voted for and against the general principles of that bill. They've been hearing evidence over the last week. Like Liam's bill, they've received a huge amount of evidence and are going through the line-by-line scrutiny of that legislation in the coming weeks, with the expectation that it will come out of that bill committee for report stage towards May time. In that committee stage, there may be amendments tabled to the bill, and indeed when the report stage comes back to the House of Commons, there may be additional amendments agreed to the bill there. And then third reading is actually the vote on the legislation and on the specifics of the legislation. It then goes through exactly the same process in the House of Lords, again in terms of those different stages, which just kind of shows you a little bit there in terms of the different stages. So the bill in England and Wales has a very long way to go, but actually in terms of timescales is much more truncated than the experience that Liam has had, in that if this private members bill does not progress and complete both of those progresses through both houses by the conclusion of this session of Parliament, which is likely to be sort of September, October time, based on when the last King's speech was, which was after the general election in July, the bill, if it has not completed all its stages, would fall anyway. So it's a complicated and sort of treacherous process. In terms of my own views and where I am, I voted for the bill at second reading. One, because I felt that there was a locus for me as a Scottish MP, given the reserved implications that I've referenced. Second, because a lot of people had written to me with their views. But thirdly, because in terms of general principles, I thought the bill deserved to have further scrutiny. And the fact and testament that so many of you are here this evening shows how important that bill is. Like Willie, I've not come to a decision about how I will vote in later stages, but I am obviously following the bill with great interest. And obviously, dare I say, I'm now the barrier between the questions from the floor and here. And I think it's much more important for Willie and I that we hear from you. But that is just to give you an idea of it. So you will see, obviously, this bill is called the Terminally Ill Adults Bill, and that gives you the difference between both of them. So thank you for that.
Right, thank you very much, Wendy, Sarah and Liam. We're now going to questions and contributions. We have two assistants, one with a mic on either side. We're going to take groups of 3 questions, and if you can keep them, as I said, as succinct as you possibly can. If you can say who you are, if you prefer to say where you're from, you can. But if you can say who you are and then ask your question or make your point. So I'm going to take Donald up here, and take one down here. And I can take anybody from this side. Yeah, and on the far side, Ewan. So, Donald first. So if you do them.
Good evening. My name is Donald McEwen, and I'm currently the chaplain in St Andrews University, and I was, for 10 years, parish minister in St Monans and Largo Ward. I'd briefly like to make 2 points. And I'm generally, these points are concerns that I would have about the bill and about its passing in either parliament. One point is, I think, most connected to my previous role as a parish minister in parishes which were significantly working class. These were communities where I would visit people often in hospital and in their homes when they were ill. And it was clear to me at those times that people who had less education than is found in the university were very trusting of authority in hospitals and had very little sense of agency over their own medical care. And it seemed clear to me then, because these things were being debated, and clear now, that many of those parishioners and people without much education would be likely to feel not an external coercion, but an internal coercion within themselves, that they would feel pressure, if this becomes law, to make things easier for their family, for a stretched National Health Service, which they love, and indeed for society as a whole. In other words, I think this bill works for people like me who are used to having agency, to making rational decisions based on, in my case, 3 degrees. I think, though, if we pass a bill like this, we need to think about the whole gamut of society, including many people who are used to doing things in favour of the whole, even if it's not their own view. My second point, in this job as university chaplain, I spend a great deal of my time supporting students and staff who feel that they do not have hope and that they wish to take their own life. Now, I know perfectly well that the laws before the parliaments would not allow someone to go forward for assisted dying because of mental pain. However, if we as a society, through our parliaments, decide that it is acceptable and legal to take one's own life in these circumstances of terminal illness, my feeling is that I have lost an argument to give to the person who feels without hope for mental reasons not to take their life. In other words, we as a society are saying it is okay when one feels pain to end one's life. I don't think that is okay, and I want to continue to support students and staff and others to continue to find hope in the midst of pain. And so, those are my 2 deepest concerns about this legislation. Thank you.
My name is Norman Coburn, also from the East Neuk of Fife. Actually, Donald, I was going to ask pretty much the same question. I know of situations where I would be gravely concerned about elderly people effectively being coerced into accepting this as an option to end their lives. Come on, Mum, you've suffered enough. You've suffered enough. Just let it finish. So moving on from that, I'm struggling for the whole reason for the. I mean, the point that Sarah makes is about the whole kind of palliative care seems to me the big issue. Because, I mean, I've had 4 close family members, including a sister, who've died of cancer. They've all been fortunate enough to have good palliative care in hospices. And they had time to end their lives peacefully and for the family to grieve at their bedsides before they left. So the children didn't feel abandoned by grandparents. They didn't feel kind of left to cope. So I think that's very important. I would hope that Sarah's concerns about palliative care would be recognised by our various parliaments.
Ian Bradley, and I should declare an interest. I'm a member of the faith group of Dignity in Dying, which brings together religious figures who are broadly supportive of assisted dying, chaired by Rabbi Jonathan Romaine. I've got 2 questions, one specifically for Dr. Mills. You gave a very, I mean, all of you, I thought, gave wonderfully measured and balanced statements, but you presented a lot of concerns about the bill. I want to ask you whether you would agree with me that the reason we need this bill is because of the way medicine has gone in the last 100 years. If we'd been here 100 years ago, family doctors would have given opiates to patients who they knew were dying gently, and they would have assisted them into what I and many here believe is another and better world. But because partly of the fear of litigation that is so strong now in the medical profession, you know, you're terrified that people are going to sue you, and also because the whole thrust of medicine over the last 50 years has been to try and keep people alive at whatever cost. And I would have to say at whatever cost. It seems to be in an ideal world we wouldn't have the need for this legislation. But I'd just like to ask you whether you think actually that the way medicine has gone is really the reason we have it. And I'd like to ask Liam McArthur and Wendy, there's a lot of talk, and you do mention it in your paper here, there's a lot of talk about whether actually this can be really a devolved matter or whether it's a reserved matter. Now, it would seem to me very unfortunate if we have different legislation in Scotland and in the rest of the UK, and we might end up, you know, rather as now people have to go to Zurich, which seems to me to be awful, we would have people... We would have to, well, it's a nice place, but not, you don't necessarily want to go there to die. But, you know, we might have 16-year-olds coming to Edinburgh. We might have, it would seem to me if we can get some kind of UK-wide bill, which brings, now there are obviously significant differences, but I'd be very interested to hear your take on whether you feel there is a chance of getting UK-wide legislation, because it would seem to me it looks, you know, the English or the UK one seems to be going through, I would expect on what we hear, the Scottish one probably to go through Holyrood. Is there any chance we could have, do you think, some kind of UK-wide legislation? Because it would seem to me an unfortunate issue, particularly given all the emotive connotations, if we're kind of going in different directions. So one specific question to Sarah about whether medicine is not in some way responsible for us having to have this bill, and one about whether we can get a UK-wide bill. Thanks.
Thanks, Ian. Liam, do you want to go first?
Am I okay to sit, or do you need me to stand? Sitting seems fine, yes. Okay, let me maybe take them in reverse order. In terms of a UK-wide bill, I can understand the attractions of that. I think it's probably not unhelpful that both bills are being considered by Parliament at the same time, so there's an opportunity for Willie and our MSP colleagues to see what is happening at Westminster, and there was certainly considerable interest amongst my MSP colleagues in the debate, the stage 2 debate that took place at the end of November in Westminster. And a lot of the arguments are the same. I think it's fair to say that already, I mean, health and care are devolved issues. The delivery of health and care in Scotland is different from other parts of the UK, sometimes in quite pronounced ways, and others more subtle and nuanced ways. As I say, there's no two pieces of assisted dying legislation anywhere in the world that are the same. As well as the legislation going through at Westminster, we're also seeing bills well advanced in the Isle of Man and in Jersey. And I don't think any of them will end up being exactly the same, should they get to the end of the processes. And as Wendy said, I mean, that's not a foregone conclusion, nor is it in Holyrood. But I think they will lean on each other and learn from each other as they go through that process. And I don't think that's necessarily a bad thing. There's a residency requirement built into my bill, as there is in Kim Ledbetter's bill, which would require somebody to be resident in Scotland for a year, registered with a medical practice in Scotland over that period. Now, there's been evidence taken as to whether or not it's a sufficient barrier to kind of cross-border flows. I rather think that those who would be eligible to meet the criteria, the prospect of them taking a decision in the timeframes that are likely for those sort of decisions to be taken, it's unlikely that they would wish to up sticks, move away from the support structure they have around them wherever they're based in order to reside in Scotland and apply that way. You can't rule it out, but I think it's unlikely. It may well be that Parliament believes that it should be a longer period of residency requirement, but even so, I think that's less of an issue. I'll allow Sarah to come back on your other questions, although I would say that in terms of double effect, withdrawal of treatment, refusal of food and drink, palliative sedation, a lot of those, I mean, those are things that happen at the moment. They're legal. I think they put medics very often in a fairly grey area, and certainly in a number of instances don't involve a terribly great amount of patient input. Turning to the first couple of questions on the issue of coercion. I mean, as I say, I think that sounds portentous. I think the issue with coercion is one that is raised routinely, and I think it's probably fair to say that examples of overt coercion are probably unlikely. The issue that's probably more wicked for MSPs and MPs to get their heads around is how that internal coercion that was referred to by Donald might apply. I think it's fair to say that the proposals, whether they're amended or not, the proposals as they stand in my bill would mean that assisted dying would be the most heavily safeguarded end-of-life option that's available. You would require the diagnosis of not one but two medics, both on the terminal illness and on mental capacity. You would be having a discussion around the rationale for that decision or that request having been made, and where it exposed issues about sense of burden or inadequacy of care, whether that's social care or palliative care, there is an opportunity for one and probably both of the medics to say, hold on a second, these are the options that we need to explore before we pursue this further. I think this is a process that rests heavily on the judgment of medics. And I think to assume that medics that we trust with life-limiting, life-ending decisions right now will suddenly be unable to exercise the judgment that we expect of them now, I think is unreasonable. I think in terms of what we see from other jurisdictions, in terms of those accessing it, I know that there have been concerns raised by a number of my MSP colleagues about that sort of socioeconomic demographic issue about accessing. I mean, I suppose, sadly, but maybe rather predictably, this is in other jurisdictions similar to other health and care treatments where those in higher socioeconomic brackets tend to access this option at higher levels than those in lower socioeconomic groupings. And I think the issue of coercion from family members is an interesting one. The image of sort of nefarious family members trying to shuffle Granny off this mortal coil in order to lay hands on the house and wealth is just not borne out by practice. I think the far bigger issue, and it's come up in evidence to the committee, far bigger issue in terms of family coercion is trying to coerce Granny or whoever it is out of the decision. That it is difficult for family members to, I think as Donald was saying, to see a loved one going through this process and perhaps making this decision. But actually, again, from the evidence, the ample evidence that's come through in terms of the written evidence, the Health Committee hasn't necessarily found itself able to take oral evidence from those with terminal illnesses or those who have supported a family member through this process in other jurisdictions. But all the written evidence points to the fact that that grieving process is invariably far easier where that element of control and choice at the end of life is exercised by the patient. And it's not to say that some family members find that more difficult, but I think we don't have to guess at how this would work in practice. We see in the jurisdictions where terminal illness, mental capacity models of assisted dying exist, who accesses it, why they access it, where roughly in their treatment or palliative pathway they access it, the impact on the patients but also family members. We have ample evidence of how this works. So we need to go through this debate. We need to raise the what-ifs and how specifically this would work in a Scottish context. I think Sarah's right to point to some of the pressures in terms of health and care. I can't remember a time in the last 20 years where we were all agreed that the health and care services were in the rudest of health, so we should all crack on. And that, at the moment, we are seeing that the status quo has consequences. At the moment, we're allowing a small number, but around, I think it's 15% of those that are accessing Dignitas services in Switzerland, and the spokesperson from the Switzerland Tourist Board, I think, probably needs to refresh on the speaking points. But 15% of those are coming from the UK. So we are allowing assisted dying, but only for those that have the financial wealth and the physical capability to get to Switzerland. Far more, we know, are taking matters into their own hands and suiciding. Some of it successfully, some unsuccessfully. And the additional trauma that brings both for the individual and their families, I think, is a consequence we cannot ignore. Not introducing this choice, not passing legislation of this nature, will have consequences. Okay? Thank you.
Sarah, do you want to?
Right, so there's a lot to respond there. In terms of agency and autonomy, I think that's a huge concern. I think that it's borne out, if you look at other countries, who is accessing assisted dying. Actually, it's predominantly people who are white and who are university educated. And actually, it's yet another example of where we have huge inequities in how people access care towards the end of life. I share your concern that people who do not have a huge sense of self-agency would feel pressurized into accepting an assisted death because it would mean that they were using fewer resources and having less of an impact on family. If you are in a family where there is people working 3 jobs to make ends meet, where there's concerns about money, feeling an internal pressure to justify your continued use of resources in a resource-poor setting can be hugely difficult for patients to justify choosing to continue to exist and choosing to consume resources, which is profoundly sad. And I think that the message that this bill sends to people in that setting is very difficult. I agree with the concerns in terms of mental health. Certainly in Canada, when the legislation was introduced, it was not intended to include mental health. There have been, so there's one court case going through at the minute where somebody was admitted to hospital because they were suicidal. When in hospital, they requested medically assisted suicide and were given it. And the person's sister is now suing the people involved in that because they said, well, we admitted them to a place of safety because they were suicidal and you killed them. It's the kind of thing where we've seen in every country where this legislation's been introduced, it's been introduced for a very small percentage of the population in a very narrow window, and it has expanded over time in terms of number of people accessing assisted dying and in terms of conditions that are covered by assisted dying legislation. So again, with Canada, we've seen a 31% increase year on year for people accessing assisted dying. It's now 5% of deaths in Canada are due to assisted dying, 17% of deaths in Quebec. When the legislation was introduced, there was no intention for it ever to become that big as a cause of death. It was very much intended for the very few people for whom even the best palliative care cannot control all of their symptoms. So I absolutely share your concerns in that. Last 100 years of medicine, I'm broadly in favour of it. Mostly penicillin. That was good. We have strayed a little bit in terms of something, and certainly the individual relationship that people used to enjoy with their doctors has gone. It used to be that you would have one doctor cradle to grave and that they would know you very well and that they would not have to check for your wishes or your coercion because they had known you for decades and were able to have that intimate relationship with you. We're now in a position where the majority of people don't necessarily know their doctor or even have a named doctor. We have practices entirely staffed by locums and run by the health board. We have waits for GP appointments that are in weeks, if not months, difficulty in accessing face-to-face appointments. It has broken at the seams in terms of the system. I don't think the solution is to introduce assisted dying. I think the solution is to fix the system, and I think it is still fixable. Sorry? I mean, we'll be sued if we do anything in medicine. Definitely if you kill. No, I mean, in terms of litigation. So certainly, we do give opioids at end of life. That's a predominant form of palliative care is the provision of opioids. The double effect principle very much states that if you give opioids with the intention of curing distress and suffering, and that happens to hasten death, that is allowable. We are aware that high doses of opioids depress breathing and that people will die in a shorter time scale if they are in receipt of high doses of opioids. We still very much do this with syringe drivers, and you know, so certainly I would argue that doctors are not withholding care from someone out of a concern for being sued, and that palliative care, when correctly and thoroughly delivered, does involve the use of drugs that can hasten death, but not with that intention. I certainly think that doctors being protected from litigation is a concern. One of my concerns is that there be a requirement for doctors to proactively bring up assisted dying with patients. So as a physician, you are required to tell everyone what all of their treatment options are. Someone who's not aware of their treatment options would not be deemed to have informed consent because they would not be informed. If assisted dying is a treatment option, you would be required to raise it with a patient proactively in the same way as you would raise pain relief or any other treatment, which would mean that patients who perhaps were even unaware that it was something that they were allowed under legislation, and perhaps in the context of having an initial discussion where you say, actually, this is no longer curative, we have to move towards comfort care and we're not going to win this fight, have you considered assisted dying? That is challenging. It's also impossible as a doctor to bring up something in a neutral way. So if I say to you, have you considered quitting smoking? I'm not neutral. Saying, have you considered assisted dying? I think patients would feel a tacit pressure to consider it because their doctor is recommending it. And actually, quite a lot of patients listen to us, not everybody, which is fine. But it's still very much something that could not be neutrally brought up in a consultation, particularly one as emotively charged as conversations around dying.
So that's taken 25 minutes, which is great because actually the depth of the detail of the issue we need to get into is significant. But I'm hoping we can try and get through a few more questions, so don't feel the need to answer everyone, but if we're able to get through a bit more succinctly, we can get more people in. So I'll take lady here, and come back to you in a minute, and then you and the gentleman at the back right, at the top there. So yes, first here.
Thank you. My name's... Can you hear? Is that okay?
Yeah.
My name's Sarah Heald, and... okay.
Hold it closer.
I can project my voice?
No, hold it.
Okay.
Just hold it closer.
Is that better?
Yeah.
Is that better? Okay, thank you. My name's...
No.
Hold it.
Oh, here?
Yeah.
Okay, thank you. My name's Sarah Heald, and I'm sort of speaking partly about I want to ask some questions about how the legislation would go forward. I don't know how many people in the room, probably quite a lot, have had the experience of sitting beside people who've died as they're dying. I've been very privileged myself to have been right beside a few people who've died. I've sat with animals that have died when, you know, in this society we have an enormous reluctance to see if a natural process will go forward rather than euthanize our animals. And, you know, I have seen a lot online round about the dignity of dying debate where people say, oh, well, we let our animals do it. Why should we not? But I know it isn't supposed to be too philosophical a discussion, but I think it's really important that it is. Because in this society, I feel so many are actually terrified of suffering. And I think that some of the motivation towards having assisted dying bill relates to people's actual inexperience of death, of being in the moment of death, or of being in the moments around death. You know, I've also been with friends in hospice, very, very close to their ends. And, you know, when you see, one of my friends passed away on New Year's Eve this year. And she said, she'd gone home from hospice. And she said to me, you know, people think you go to hospice to die. For me, it taught me to live. And for people who haven't had the experience of having that quality degree of palliative care, she was actually in Yorkshire, they don't have, to my mind, the means to make a clear decision. Okay. And until these sort of resources are sorted out, how can they make a clear decision?
Sarah, could you make one more point?
Oh, sorry,
perhaps,
yeah.
And then, because I'm trying to get lots of people in.
Okay, so very, very quickly, I'm very concerned about resources for GPs. You know, I mean, I've spoken, some GPs are fantastic, some have actually no empathy. How are they going to be trained in empathy for discussing it? You know, and people who, as Donald said, the idea of hope, and people who, you know, in the pandemic, how many people actually didn't go to hospital to consult about their cancer because they were saving the NHS? And I feel this is relevant to the argument.
Okay. Thank you very much, Sarah. Appreciate that. And the gentleman at the back. And
hello?
the young
You hear me okay?
behind, yeah.
Hi, my name is Alan Finney. I live in Cooper. My point is fairly narrow, I'd like to think. My experience of the subject is largely framed around my father's death. And I just want to pick up on the points that Sarah was drawing attention to at the start of her points. And I felt there was a lot of emphasis there on a lack of palliative care, and that wasn't sufficient. And we could address this this issue by improving access to it. But in the case of my father, he had good palliative care, and he suffered terribly in the process of his death. And for sure, he would have taken the option if it was available to him. So I don't think there's enough. I feel as though there's a lot of emphasis on just get more palliative care, that'll work. It doesn't work, in my experience.
So my name is Alex, and I am a neuroscience student here. And we have heard from Dr. Mills all about the consequence of the gaps in the NHS budget and how they affect the palliative care in the UK. And I feel like my biggest fear when it comes to assisted death is that with the gaps that we have right now, especially in the mental health services, how can we assure that every single patient who is requesting the assisted death will be actually properly evaluated when it comes to whether they are actually able to consciously make the decision, when we are seeing how people suffering from depression, from PTSD, from all of those horrible diseases are genuinely not getting just help in time. So how can we make sure that people who are wanting to make this decision are actually able to do it?
Okay. This lady here. And you go,
Stand
yeah.
up, I'm not good. Can you hear me?
Yes.
I'm from Wormit, and I have a rare progressive autoimmune disease that most people here won't have heard of, apart from Dr. Mills. I'm sure probably will have. It's called systemic sclerosis, and it would make me eligible. It would make me eligible for assisted dying, I think. And my concern is that it took me 12 years to get definitively diagnosed because it's so rare and because of, you know, the vagueness around it. And treatments are not necessarily available to many people. And if I was given that choice, it would be on the basis that it carries a high mortality risk. And yeah, I know people who've had this disease, who've died of it, who have died unexpectedly. And I also know people who were given a very short sort of span of life expectancy, who've then gone on to discover treatments and have reached a state of sort of more or less stability, disease stability, and have lived a good 20 years with it. And so I suppose my concerns would be about the medical profession not knowing enough. And I would feel at times that I might want to go ahead with this. And if it was offered to me, I know too much about being in hospital to not be tempted. And so it would be that self-coercion that would be the problem.
Okay, thank you. And just really down here.
I was a medical student here 70 years ago, and the advice
A bit closer, a bit closer.
I was a medical student here 70 years ago, and the advice I was given then followed me all my life and was a great help. And Prof. Hill, who was a professor of medicine, said, "Thou shalt not kill, nor shalt thou strive officiously to keep alive." And I've had that maxim all my days.
Thank you. Can everybody hear me well enough? My name is Colin McAllister. I'm from St Andrews. I think the title there, Assisted Dying, gives the game away. This euphemism, instead of saying assisted suicide, suggests a slightly guilty conscience, a desire to sugar the pill, as it were. Now, I don't dispute Mr. McArthur and all other people who are in favour of this have good intentions. But it is well said, the road to hell is paved with good intentions. I think we have to avoid emotion in this and look at reason and facts. Now, I don't want to go too long, but I'd just like to, this is based on evidence. Number one, intractable pain is not the leading cause. Two, an assisted death is not peaceful and painless. Thirdly, safeguards are progressively ignored and removed. These things have been said earlier. The vulnerable are put at risk, we've had that before, and overall suicide rates go up. So I think, although the intentions are good, the idea is not well thought through. Thank you.
Okay, Sarah, do you want to answer some of those questions? Thanks very much for your contributions, by the way.
Yes, absolutely. Thank you, everyone. In terms of the point on teaching empathy, we are very much doing communication skills training for doctors now that didn't exist certainly 70 years ago, and I think we probably don't have Professor Hill anymore, though I haven't checked. I think it's very important to make sure that all doctors are specifically trained in empathy and communication, and I think we're doing a good job of that here. I take the point in terms of people feeling that they need to save the NHS by sort of opting out of using resources in that last year of life, and there's a huge amount of pride in the NHS and wanting the NHS to succeed, and that sort of coercive pressure on people feeling that they shouldn't be using NHS resources. Absolutely want to respond to the point at the back about what happens when the best palliative care isn't good enough. It isn't always good enough. We can't fix everything. I wish we could. It would be a simpler and more beautiful world if we could. I would argue that the palliative care that we're doing here and now is still at its best not as good as it could be. And I say that with a huge awareness of the limitations of resources. We are really going above and beyond to try to provide the best care humanly possible, but it's still within the constraints of a system that is very, very limited, very overstretched, very resource poor. Even maintaining our current resources, you know, the community hospital at the Adamson, we're constantly fighting to stop beds being closed and taken away there. It's challenging. And even in a world in which you've received, or family members have received, the best palliative care that we can offer, it isn't as good as we could do, given more resources or even more research into how to allocate the resources we have more appropriately. And even in a world where the best quality palliative care was available to everybody, there would still be people who suffered. I won't pretend that isn't the case. My concern is that those people would not necessarily be helped by this bill. So people who are very much suffering in their last days in life, this bill doesn't cater for that. This bill has a 14-day clause in between the first and second request where there's a cooling off period for patients to think about it. I mean, most of the time when you're in a phase of acute suffering, it's days to short weeks. And the people who are acutely in that suffering would not necessarily have capacity and agency to execute the terms of this bill in order to request it. So that's sort of saying the way the bill is written doesn't necessarily address the scenarios where you could reasonably expect that somebody would want assisted suicide, but does address a number of much wider conditions where it wouldn't necessarily be a thing. And also the huge proportion of deaths that we've seen in countries where they've introduced it, it's not that 5% of the population of Canada had intractable suffering. You know, it's the amount of people who are taking up assisted suicide in these countries is not necessarily the people that you would reasonably expect would be in need of it. But I am hugely sorry for the suffering that they experienced. You were raising your hand up. Do you want to come back? Yeah. And like any legislation, it will never fit everybody, and there will always be winners and losers for anything, you know, from seatbelt laws through to assisted dying. There'll be people who don't fit nicely into the mold that we have, and I think the onus is on us to choose a legislative path that caters for the majority of people and that provides the best care humanly possible on a population level, but it will not always be the right thing on an individual level. And certainly if there was such a legislation, I'm not clever enough to write it. I don't know anyone is.
Okay. I think it is impossible to draft legislation that will deal with 100% of cases. I think the best way, though, of improving the situation we have at the moment and maximising the number of winners and minimising the number of losers is to add an additional choice, which is a choice, it's not a requirement, it's a choice that would be accessible to a very small number of individuals. The vast majority of people will die, whether with palliative care, with social care, with a fairly limited care at all. But we know that the cases at the moment where people, despite the best endeavours of palliative care, and excellent palliative care, world-leading palliative care, are still enduring bad and needlessly painful, whether it's actual pain or existential pain, painful deaths at the end of life. And that is not just an endurance for them, the trauma it leaves for those they leave behind should not be underestimated either. I think the point about an inexperience of death, I think quite the reverse, this point Sarah was making. I think the consultation this time around, I mentioned earlier that we've had 2 previous bills that Parliament's considered. The difference this time round compared to the previous 2 times that this has been considered by Parliament is the extent to which people, either those with a terminal illness or those who have lost somebody to a bad death, is off the scale. This is a debate that needs to be informed by the people for whom it is intended to benefit. We need to be careful that the safeguards are put in place to protect the vulnerable. I get the wider issue around the message that's sent out, but at the moment we are accepting a situation where we know suicide levels amongst those with a terminal illness are 2.5 times the size of those for the population as a whole. We know that a significant proportion of those that Dignitas are dealing with are from the UK. We have outsourced this issue because we have not managed to grapple with it. I think the point about GP training, I absolutely get that point, and it's come up quite a bit in the evidence to the committee. I think it's not just about the skills training, it is the empathy that you talked about, and actually the peer support within the medical community is something that we've seen develop in each and every instance, usually not through formal mechanisms, but through informal and organic structures. The point in terms of mental capacity that Alex made, absolutely. I think something I probably should have alluded to in my initial remarks was that the diagnosis of terminal illness mental capacity would need to be made by 2 separate doctors, but either who had any concerns or questions around possibly the terminal illness, but probably more likely in relation to capacity, would have the ability, the expectation would be a referral to a specialist in that area would inform that decision. So I think what the legislation will require to happen, and what I would expect would happen in some instances, is that other practitioners would be involved. I think earlier there was a mention made of Chaz. For those at the younger end of the age spectrum, almost certainly the numbers are going to be vanishingly small in that area, but actually the complexity of their care is almost certain to involve many more individuals. Social care sector have also talked about the need for them to be involved in decisions and assessments that are made, and I think that's absolutely the case. So what the legislation can require doesn't preclude other things happening, and I absolutely believe that that's how it is worked, because we see that working in other jurisdictions. We don't need to guess at how this works in practice. We need to engage a degree of imagination, given that Scotland's circumstances are slightly different, but not so different. I don't buy into the Scottish exceptionalism that we can find a way of making this not work when so many jurisdictions have made it work. And the final point that I think Colin made about euphemism. Language is important. Language is important, but those who seek to describe this as suicide do it very deliberately. The decision about whether or not a person with a terminal and advanced progressive terminal illness is whether or not they're going to die, that decision's been taken. The mental state of the vast majority of those, and we heard this in evidence from medics in California when I was over there with a cross-party delegation at the start of last year. It could not be more different from somebody who is considering suiciding. They want to eke out every last minute that they've got, but when it all gets too much, they want the reassurance that they can have a degree of choice and control over how and when they die. So I think conflating it, and the Australian Association of Psychiatrists have come out very forcefully and cautioned against conflating what is involved in assisted dying legislation with suicide. Yes, we need to ramp up our rates. Suicide rates in this country are far too high. I would argue, as I say, that in part that's because of the lack of choices that are available. Safeguards that have been introduced in terminal illness mental capacity legislation in jurisdictions around the world, from those that we see more recently in Australia back to Oregon at the end of the 1990s, there has been no change in the eligibility. There have been changes to the safeguards because they've worked out that some of these aren't providing any safeguards, they're just providing an obstacle. The fact that more people are accessing it is a reflection of the fact that people are more aware of it being a choice available, that medics are more comfortable, experienced in delivering it, and therefore feel confident in being able to deliver it. But the conscientious objection will not require anybody. Choice works two ways. This needs to be a choice for patients, it needs to be a choice for medical practitioners. Those involved are likely to be small because the numbers accessing it are likely to be small. There are those that will want training, will want to understand more about what it involves and how they might support patients, even if they do not want to be directly involved themselves. And that is right, and that is proper, and that's what we see happening in other jurisdictions around the world. So in terms of that language, yes, we need to be careful, but we need to be careful not to stigmatise people who are looking to have a good, dignified death on their own terms.
Right, let's get through some more questions. Right, so the lady there, and then at this side, Ewan, over here, the lady there in the third row.
Hello, I'm Ruth. I'm a student at the university, and I think one of my main concerns with the legislation is that you said a little bit about Scottish exceptionalism there, and just that it looks very tight in comparison to places like Canada or other states in the US. But how can we guarantee that in 10 years from now we wouldn't end up in a Canadian situation? Because I think most people, even people in favour of legislation, would not want to end up like Canada. Thank you.
Sorry, the lady has stepped back to allow me to speak, so I'm Moira Henderson and I'm going to chuck in my MBE. I'm owner of the Rings Holiday Accommodation and I was a nurse. And at age 20, I stood in the doorway of and prevented a doctor from going into a very elderly lady because he was going to hurt her. And basically, her body was packing in. So I have been with people, I've sat with them, I cared for my own mother. The Rings was developed. It's an accessible holiday accommodation. It was developed because my cousin had a terminal illness very similar to motor neuron disease, and he was a very strong advocate for people with disability to his very last day. I have had numerous people come to stay with us who are terminally ill, come with their carers, come with their family, and they all want to live their life. They want to live their life as best possible with whatever constraints or whatever difficulties they've got. And I think as a society, instead of having this discussion, I think we should be discussing, as I was in a Zoom Teams programme call last night with Fife Council, we need to be looking at accessible accommodation in all housing, right from the word go, so that somebody doesn't get lifted in, as I know somebody who was lifted from the hospital into their own home and became a prisoner in their own home with no toilet facilities. They had to use a commode. How long could you cope with that for before you would maybe consider this assisted dying? We're in a very dangerous situation here. People want to live, and as a society, it's up to us to facilitate that. And yes, we've got lots of problems. And actually, do you know what? I think we need to rip up the paper and start and think and talk about housing. Talk about how we can provide good quality care. Yes, there are lots of people who are living today who've never sat beside anybody who's dying. They're terrified of it because they don't know what it entails. It's that unknown. It's the fear of the unknown. And the fear of the unknown that I think is actually promoting a lot of people to even consider this. Coercion? You bet your bottom dollar there's going to be coercion. And a doctor will not pick it up. They will not pick it up. And that's a terrifying part of this. And our judicial system that has failed so many post office masters, are we really seriously going to allow this serious, important question? I'm sorry, folks. We don't have the right to say that people can assisted dying. It's not fair to put it onto doctors. That's my point.
So the lady at the back, and then Peter at the back as well there, just on the back line.
Okay, thank you. I'm Jessiwa. I'm a student here. I think the MP started by saying we think a lot about saving lives, but we don't think about death. And I thought, yeah, that's true. My research is on why people take the law into their own hands. And we saw that it's because of norms. And then there are knife crimes, death from drugs, starvation, loneliness, bullying in schools. Before deciding to do my PhD, I was a teacher for more than 7 years in high schools in Ghana, where I'm from. Children struggle. They never talk about death. when I landed here, my first interaction with a teenager, I want to die. The first time I was really shocked. So I thought, okay, maybe death is discussed freely here. And this were fairly healthy youth. And all the time, I want to die, I want to die. My problem is, perhaps I would understand if someone I love is dying. I don't know, maybe, but I just can't imagine it because I feel, what about the unintended consequences? A 16-year-old can decide, I'm suffering too much, so I do not want to live. I feel like we are becoming a society that is so much afraid of pain. And that's where we lead, I know good intentions, but where bills like this are led by politicians rather than medical professionals. I find that it's like you go to Glen Rothes, abandoned communities, nothing being done, and then we come here talking about sister dying when there are many things that can be done. So for me, my question is, what are the unintended consequences? Because this is going to create a social norm where it's easy, you can just die if you want. How can you prevent that from happening, especially when the youth are already abandoned and think death is the way out of everything?
So, Peter at the back and then the lady down the front here.
Hello, Peter Keelman, Newport-on-Tay. I'm a retired GP. I was a GP in Aberdeen for 25 years. Sorry, I'm not standing up. I've had 2 knee replacements and had to retire from general practice because just around about COVID, I was seriously with a chest problem and was on oxygen for over a year. So I'm seeing this issue from both points of the view as a patient just now and as a doctor. As a young GP, I looked after a large 120-bedded nursing home which contained 30 EMI beds, elderly, mentally infirm beds, and I had a lot of conversations with nurses, patients, family members about people who were very ill and dying. I had 2 very clear times when I was explaining to a relative about a person's illness and the options that they had, whether we should keep them here with nurses they knew or rush them into the hospital and what could be done in the hospital. And the relative said to me, "Come on, doc, can you not just do something here?" It happened to me clearly on 2 occasions, and I've spoken to lots of other doctors who've said that relatives have spoken to them about that sort of thing. I was an inexperienced young doctor. I didn't report it or anything. I didn't take the advice of the relative. I actually tried to do my best medical, doing no harm and doing the best for the patient. I then went on to spend a lot of time caring for dying patients. I was a Macmillan lead GP in the northeast of Scotland for 10 years, looking after training of doctors and nurses in end-of-life care. And I can remember several patients in my practice. See, I was one of those GPs who had the privilege of seeing folk that know me well and families. I would look after 3 generations. And I had several people who would come up to me and say, "Dr. Peter, can you not just, give me the blue pill?" That's what they called it in Aberdeen. It was before Viagra. And people would say, "I'm just done. I'm really done, doc. Could you do something?" And I remember one guy who was an elderly gent who'd got prostate cancer and it had spread. And he said, just you know me, can you not just do something? And as a doctor, when people come to me, I don't just do as they say. I try to explore their concerns, their worries. And I spent time to say, well, first of all, I can't do anything, as you're suggesting, to end your days because it's not legal. But there's lots of different things. What is it you're worried about? What are you concerned about? And I went with that person and many other people over a period of time. I prescribed things, I referred them to different people, to nurses, to specialists. And I can remember that person coming back to me a couple of months later and saying, I asked you to do me in, doc. Wasn't that daft? And that's happened to me on several occasions. And I've seen many people who have been scared, worried, frightened. But when they've had decent palliative care symptoms have been sorted, pain has been sorted. They've had time to make peace with themselves, often make time, make peace with family members. And I really fear that this would shorten that possibility for people. My understanding is that safeguards always don't work in other countries, and they always get much, much worse.
Peter.
I read the British Geriatric Society, 5,000 expert carers of the elderly, and they said the problem is under-resourcing of health and social care, including specialists in palliative care, which in the worst case, the lack of old people's services has led to neglectful care in some settings, including abuse and societal negativity. The BGS is concerned that older people may be directly, indirectly or tacitly influenced to choose assisted dying because of adverse factors within our society, which may otherwise be remediable through positive care.
Thank you very much, Peter. I'm going to have to stop it there. Thank you. The lady down here, and I'm going to take one more, and the lady there as well.
Can you hear me, yes?
Yes.
I'm Anne Bridges, and I have only a personal experience, or a second-hand personal experience to offer. My mother-in-law, who was a very healthy lady, lived to be 96 actually. At 91 she was diagnosed with skin cancer, which was slow, took a long time to come about, but she knew it was going to come about, and she knew it was going to be horribly painful in the end. She hid her pain for as long as she possibly could, and eventually she had to go into hospital, and she was then given palliative care. She, at one point, about 1 week into the palliative care, which was not working, it wasn't their fault, it just wasn't working, she wanted me to smother her. She said, "Could you take that pillow and smother me, please? This is intolerable." I said, "Sorry, I can't." Unfortunately, for a lot of that time, I was actually working in Edinburgh, and my husband was sitting beside her, and he could do nothing either. And he sat beside her for 6 or 8 weeks, and then eventually in great pain, because she could no longer swallow, she could no longer eat, the pain was not being controlled, she died of basically starvation and thirst. And a week later, my husband hanged himself.
Right. Okay. I'm going to take one more, and then we're going to have to close, I'm afraid. Just the lady here.
Hello, can you hear me?
Yeah.
Yeah. My name is Anna-Marie Querido. I come from Pittenwien, although you wouldn't say so by my accent, because originally I'm from the Benelux countries. My mother was terminally ill in the Netherlands, and she had, and I use a different term now, seen to it that it was allowed that she would get euthanasia. And she was terminally ill, as I say, and she had the interesting, well, I visited her regularly, and at a certain stage she said, "Well, you know, if I can't walk to the shops anymore, then life can be over for me." And then a process started. She said, if I can't walk, she lived in a residential home, and she said, if I can't walk to the end of the corridor anymore, then life can stop for me. And so she kept moving the goalposts. And at a certain point, she had a carer coming in to shower her in the morning. This carer found her sitting on a settee with a cup of tea which she'd made for herself, and she had died of natural causes. And I think that was what she had wanted. But the fact that everything was put in order for her, that if she really felt that she couldn't cope anymore, that there would be an escape, that was a safeguard, a safety net for her. And I think it's important to look at this law from several sides, and this is an important thing, I would have thought.
Okay, I'm really sorry we've actually run out of time. There will be a survey sent out to your email afterwards for you to express any points that you want to make in addition to what's been mentioned this evening. But I'm going to give our two speakers the last opportunity just to say a few closing remarks before we end this evening's proceedings. So Sarah, do you want to go first?
So firstly, just to say thank you to everyone who's shared tonight, particularly those of you who shared personal stories. That's a huge strength in doing that, and I think it's important to acknowledge. There is obviously huge amounts of trauma on both sides and huge amounts of emotion on both sides for this. I would say in cases such as you spoke about where oral medication is impossible, that things like syringe drivers and things should be used earlier, and there is still a knowledge gap in terms of the palliative care that is available to a patient is only as much as the physician in front of them is able to access in terms of their knowledge, training and resources available to them. And certainly hearing what your family member suffered in that respect, that's intolerable for anyone watching that and for anyone experiencing that. But I would say in that respect, more should have been done and could have been done earlier. And certainly I think that choosing assisted suicide, assisted dying, and I would say on that point with suicide, it's only a linguistic problem if we still stigmatize suicide itself. And I think certainly moving towards people not talking about committing suicide and things is important. So I don't necessarily think suicide versus dying is important in linguistic terms. I think that actually more compassion is needed towards suicide in general. Just in terms of some of the language that has been used on that point, we're talking a lot about terminal illness and doctors. I would say neither of those words feature in the bill. The bill talks about people with an advanced and progressive condition that may prematurely end their life. It does not talk about terminal illness. In terms of prematurely ending life, well, the average age of death is 74, so if anyone over 74 are not allowed to die from this bill because they're not prematurely dying. The terminology itself is so unclear that we can't debate the rest of it without getting that right. It also talks about, you mentioned doctors. The bill doesn't say doctors anywhere. It says a medically qualified practitioner registered with the General Medical Council. Well, that also includes physician assistants and physician associates. So this could be a physician assistant or two physician's assistants in a high street shop doling out assisted suicide. If it's intended to be doctors only, the wording of the bill should say doctors only. And there are risks there in terms of the lack of clarity, and I think those need to be addressed. The point about the Canada, I feel like I should fly the flag for the Canadian Tourist Board. I am Canadian, it's very nice, don't go there to die. Or Zurich, which is also lovely for reasons other than dying. And certainly the doctors won't pick up on coercion. The difficulty is not just we may not pick up on it, is that you can't prove it. There isn't a test. I can't say, actually, we've done a scan and you're being coerced. Even if you're sitting there saying, I really feel you are coerced, the patient who is being coerced will say, no, I'm not. And you can't prove it because it's coercion. Also, the length of knowledge that you have of a patient is very limited. In Oregon, the average amount of time that a patient's registered with a doctor who provides them with physician-assisted dying is 5 weeks, because patients doctor shop and choose doctors who provide that as a service if they're interested in receiving that service. So it isn't the GP who's known you and your family for decades. It's a doctor or a physician associate that doesn't have a relationship with you, who is trying to determine you as a person if you're being coerced. It's incredibly challenging. Certainly, it isn't something we receive specific training on, unlike communication skills, which we do.
Okay. Liam.
Okay. Oh God, I've kept myself on from last time. Look, can I echo Sarah's thanks to all of you. I have done a number of these over the last 3 years, and even at this late stage, I still hear things that are new to me, that surprise me, and wherever you stand on this issue, whether you're still trying to make up your mind, having these discussions is important. And I think the answer to some of the concerns that are raised around how coercion that Sarah just finished with there, having the conversations allows for that to be exposed in a way that's not happening at the moment. The only gauge of coercion now is post-mortem, okay? So at the moment, opening up those discussions, having them earlier, and I think this is the point, that the suggestion seems to be, or the impression often seems to be given, that as soon as there's a diagnosis of a terminal illness, then somehow the application or the request for an assisted death goes in. There'll be lots of questions that are going around the head of the patient at that point of diagnosis, whether or not it's a shock. And those discussions going forward inform the patient about the options available, but also inform the medic about the state of mind of that patient. So those conversations are vitally important. And I think the ones that Peter was talking about, those are safeguards. Those are safeguards that would still be in place and actually wouldn't just require one medic, it would require a second medic as well. So as I said before, it is a more heavily safeguarded end-of-life option than most, if not all, others. I think the point that was being made by the students, sorry, I didn't get your name earlier, about, I suppose it was the slippery slopes. I mean, whatever we pass as legislation now, how can we guarantee that that would still be the case in 10 years? I suppose we can't, insofar as no parliament can bind the hands of a future parliament. This parliament has a track record of repealing legislation, so this goes two ways. If the evidence demonstrates that it's not working in the way that was intended, then there is the option available to future parliaments to repeal the legislation. But what we've seen in jurisdictions around the world, dating back to Oregon, is the eligibility criteria does not change. The understanding of what's available, the right that's available, as I say, the confidence of medics, inevitably, I think, result in take-up rising over a period. But the examples often used of Canada, and I understand that, it should be borne in mind that the legislation in Canada enjoys overwhelming public support, as indeed the polls suggest a change in the law here has commanded pretty overwhelming public support for the last couple of decades. I mean, it is political opinion that's struggling to catch up, and I understand why that is. I mean, it's easy enough to respond to a poll. It's another thing to put down in black letter law how this would work in practice. And there is so much that you can do in black letter law. Some of the stuff inevitably comes through in secondary legislation and ultimately in guidance. The point about terminal illness and the vagueness of it, it's not vague. The Health Committee has heard ample evidence from medical professionals, including the GMC and BMA, who are comfortable with the diagnosis as it stands. There's no reference to doctors, but registered medical professionals. It doesn't apply to physician assistants. I had confirmation of that from the GMC earlier this week because of the concern had been raised. And I think we've heard, and it's probably fitting, that the last two contributions we heard, they go to the very point. They go to the very point. Not changing the law has consequences. It leaves people at their most vulnerable in a position of being unsupported. They cannot seek the support of the medical professional because any discussion around assisted dying, even going to Switzerland where it's legal, would result in the medical professional putting themselves in a position of having the police knocking on the door and a prosecution being brought. And similarly with family members who leave themselves open to prosecution. And we've heard from the lady at the end there about the experience in the Netherlands. Now, the model I'm proposing here isn't remotely as expansive as that in the Netherlands. Again, a country where this has been long established and enjoys overwhelming public support and indeed confidence and support within the medical profession. Conscientious objections applying. But the reassurance it gives you that insurance policy. It's why we see consistently in jurisdictions around a third of those who make an application for an assisted death don't end up choosing it. Because it gives them the reassurance of knowing that if things get too much, that option is available, that control at the point of your life when you feel so powerless that you have that ability to exercise a degree of control has a palliative effect. It allows you to get the most out of the days, the weeks, the months, possibly years that you have left. And I think that is something that is worth a change in the law for. We need to get it right. We need to be sensitive to the concerns that are raised, but we're having the same debate as jurisdictions around the world have been having in the run-up to the introduction of their legislation, and not in one instance has a state or a country decided to repeal the legislation or roll back from it, and not in one has public confidence or the confidence of the medical profession diminished over that period. In fact, it's the reverse. It needs to go hand in hand with good palliative care. That's absolutely right. I think I will stand on any platform with Sarah and shout that from the rooftops. But what this debate has done is it's opened up that conversation. It did it in 2015 when we last had a bill. When the bill was voted down at stage 1, the debate disappeared like snow off a dike the next day. We need to capitalise on this opportunity when we're having these discussions, when we're having this debate, to make sure that we do what we can to put in the additional investment to address some of the issues around palliative care. We won't get it all right. We're not going to get it all right in the health and care services, given the challenges that they face. But denying the very small number of people the choice at the end of life to access assisted death isn't going to make that any better. In fact, it just leaves vulnerable people in an exposed and vulnerable position. And I think we can and should be doing better.
So I don't know about you, but I've really valued this discussion this evening. It's been incredibly civil, it's been emotional, it's been informative, and that's thanks to your questions. So I want to give yourself a round of applause for your contributions. And I have to say, I have been incredibly impressed by our two main speakers this evening. They have done an outstanding job.